Welcome everyone. This is John Vinson from the Arkansas Pharmacists Association. Appreciate everybody being on the webinar this afternoon. It's going to be some really good information about the Community Pharmacy Enhanced Service Network, specifically around quality and performance, and a review of some information from the first webinar. We're going to wait a couple of more minutes to make sure everybody's on the call, and we'll get started if you can be patient for just a couple more minutes. Thank you. All right, this is John Vinson again and back, and we're ready to get started. And very excited about the webinar today. This will be webinar number 2 in a 3-part series about the Community Pharmacy Enhanced Service Network in Arkansas. And I'm going to get this webinar started recording. Susanna Fuqua in our office here in Little Rock is going to be monitoring the chat. If you have questions during the presentation today, you can type those in the chat feature. There's also the ability to raise your hand if you have questions, and we'll be able to take those questions at the end of the presentation. All right, we're getting the slides loaded now, and we'll get started. So first of all, I just want to introduce our speakers. There's most of you in Arkansas know who I am, John Vinson from the Arkansas Pharmacists Association, Vice President of Practice Innovation. And we're fortunate to have Dr. Trista Pfieffenberger from North Carolina, who's a pharmacist and Director of Network Pharmacy Programs in Community Care of North Carolina. And she is going to bring you lots of really good information about quality in their network. As most of you should remember from the first webinar, North Carolina, this concept started there, and Community Care North Carolina has been around for over 25 years, but the concept of a enhanced service network and community pharmacies has been around for about 3 years. So she's going to share her perspective. And also Megan Smith, Dr. Megan Smith, is also from North Carolina, although now she lives in Arkansas and works at the University of Arkansas for Medical Sciences here in Little Rock, and has been there since the beginning of August. So coming up on 2 months, not quite 2 months, but she's an assistant professor, and her primary duties and responsibilities, other than teaching, are around the Community Pharmacy Enhanced Service Network concept and research and community pharmacy practice. So we're very excited to have her on the call as well. I just want to follow up from the first webinar and kind of give you a teaser or a snapshot in time of where we are in our trajectory. So today, September 23rd, is that second box on the slide in front of you, where we are having the second webinar. The first one back in August was a big picture overview, definitions, descriptions of the various work groups, etc. And if you look at the top of the timeline, it says identifying luminaries and work group members. We actually have 4 pharmacists, Keith Larkin in Fort Smith, many of you know him, Brandon Cooper up at Sue's Drug in Jonesboro, Max Caldwell in Wynn, and Ann Pace in Little Rock who are, have stepped forward and said they're really behind this concept and want to be spokespersons or luminaries. Work group members, there's an ability to sign up on our website at the Arkansas Pharmacists Association website. You're interested in that, or call me or text me, at my email, and you'll have this at the end at john@arrx.org. Let us know, any of us, Megan, myself, Ashley Branham from North Carolina, if you'll let us know as you think about it, if you're willing to serve on that. But bottom line is there's going to be a live meeting sometime in Little Rock, end of October, end of November. It needs to happen after the NCPA meeting, but before probably Thanksgiving, in order to get some work done to try to get this network launched for those of you who are interested. If you remember, it's about a 6 to 8 month period, and the those work groups are going to be a phenomenal way and ability to meet Ashley and Joe Moose from North Carolina, as well as Megan and myself, to get this work started. In addition, another announcement that's probably worth mentioning today is that there's another person from North Carolina, Troy Trigstead, who's going to be in Little Rock for a live seminar on Friday, October 7th from noon to 1 at the UAMS College of Pharmacy, and that's part of a I guess they do 3 speakers per year in a series for the faculty and, friends and faculty, alumni, that kind of thing. And of course, any of you are interested in this that would want to come to that, let me know, and I'll make sure you get an invite to come to that. Just a little bit of an overview of what we talked about in webinar number 1. Those 3 work groups that I'm mentioning that are needed, and we need probably 5 to 10 people that are both mostly community pharmacists or community pharmacy owners, as well as some folks from ambulatory and health systems and maybe even payers and other thought leaders in the profession of pharmacy to be available for those. But the 3 work groups, if you remember, are networks and operations, the service sets, and then quality. And most of the webinar today is going to focus on the work that some of that 3rd work group or the quality work group will be doing. So just to highlight that. Nationwide, there are about 17 states, and Ashley will probably correct me, it's probably grown, but the last I heard there were about 17 states that they were working with, 3 of whom are live now, North Carolina and Iowa, and I'm forgetting if it's Georgia, maybe it's the 3rd one, and then Pennsylvania is getting close. Okay, very good. And I also want to mention that Dwayne Jones from Harps Pharmacy is also very interested in working with the luminaries and being a luminary in the Community Pharmacy Enhanced Service Network. But bottom line, what's in it for me? So you probably watched the webinar, and if you haven't, you've got kind of an overview of what's going on. And I just want to remind pharmacists on the call today that really at the core issue is that you're going to have an opportunity for increased business and professional opportunities for better, to take better care of your patients, and an ability to participate in innovation that advances the profession of pharmacy, especially in community settings. And specifically, from a financial point of view, there will be increased patient referrals, and as the network matures and is better defined, more opportunity to participate in new payment models and potentially payment for professional services like has happened in other states. In addition, there will be marketing opportunities for your business and professional services. You're going to be visible through the Locator app and through logos that are created and news, probably press releases, etc. But why now? The reason now is a good time to join or be interested is because of the CMS Innovation Grant. You have access to consulting and learning lessons learned from other states at the NCPA convention or annual meeting, for example. If you haven't seen it yet, for those of you who are going, there's going to be a lot of programming around Community Pharmacy Enhanced Service Network, including the ability to meet luminaries from other states, and Louisiana is going to have their live meeting, and there's the ability to see what happens with the Louisiana Enhanced Services Network. And then finally, for those of you who are really patient-oriented, this is going to provide improved care and health outcomes for your patients, friends, and neighbors in your local community. So there's some financial reasons, some innovation practice advancement reasons, some improving patient care outcomes, and then if you're involved now, we have the advantage of having access to experts in this concept from other states. So there you go. All right, as we said, today is going to focus on quality, and I want to introduce Dr. Trista Pfieffenberger, and I'm going to unmute her line so we can get her expertise. So be patient for just a second. And Trista, you should be ready to rock and roll whenever you're ready.
All right, well, thank you, John, and good afternoon, everybody. Don't hesitate to let me know if there's any trouble with my audio. So like John muted, this afternoon I'm going to be talking about quality and specifically how quality relates to the formation of your local community pharmacy enhanced services network. And I've tried to tailor this presentation to where you all are on the spectrum right now of creating a CPESN. You're kind of at that early phase where you're all trying to understand the concept and you're considering whether this is something you would want to join. And then for those of you who are already saying you'd like to participate in the work groups, there's a lot of considerations coming up over the next few months. What are going to be the service sets that your network rallies around? Who's going to be in those work groups, and then what are those work groups going to do? And so I'm going to try to highlight the quality aspects of all of that here today. The quality slide on the screen was just to remind all of us what the aspects of quality are. I think it's easy to kind of focus on a network being effective or maybe efficiency, or that we're providing safe care, but really there are all these dimensions of quality that are important, and ultimately they all kind of manifest themselves in both the formation of your network and the attention to quality care at the level of your individual pharmacy. Next slide, please. I'm sure you all have heard about the CPESN work groups, the 3 work groups. I'm sure Ashley highlighted them on her first presentation to you. The group I'll be focusing on today is the one in the middle, the Quality Assurance and Performance Measurement Work Group. I will say these are the same 3 work groups that we've had in North Carolina, and I'm the facilitator of these work group meetings when they occur, so I definitely have some intimate exposure to what it looks like to form these work groups and how their conversations really change over time from the early days of network formation to where we are now in a more mature network. The role of the Quality Assurance and Performance Measures Work Group, probably no surprise based on its name, is really to identify what measures and the measure definitions you need within your CPESN to really be able to monitor both the performance and the overall quality of your network. Next slide, please. One thing that I think it's really important to consider at this early stage in the process is who your stakeholders and partners are for your CPESN, because not only are they stakeholders for the entire network formation, but they're also your likely stakeholders around quality. So if you think about your providers, clearly provider partnerships, these are the type of things that are going to stimulate referrals for specific enhanced services that patients need to your group of pharmacies that join the network. And providers have their own quality standards. They have, HEDIS measures where they're trying to meet certain thresholds of patients that have achieved their hemoglobin A1Cs and get adequate depression screening and follow-up and all of those types of things. And so they have their own quality measures, and in partnership with them, you may be able to help them with their quality measures. So really understanding the dynamics of your local providers and what sort of quality pressures they're under is a key consideration for your CPESN. Obviously, the same is true for hospitals. Hospitals are under increasing scrutiny with readmission penalties from CMS, also the hospital quality standards that came out not long ago. And so, there's data out there that say what the hospital's readmission rate is. And so you may be able to be a key partner with them in preventing readmission. So certainly you have a stake in their quality and vice versa as you begin to create partnerships ACOs are similar to providers. They have both financial and quality measures they're striving to achieve. And then, of course, you all, as your network really matures, you would want relationships with payers so that you can create a sustainable financial model for your CPESN. And again, at the bottom of the slide, just like we have on the call today, schools of pharmacy, state associations, and others can be really, really important partners and collaborators as you try to pull the network together. In particular, those groups in the collaboration realm, they have expertise around measuring quality, around the types of performance measures that you might pull together or define to be able to show success of your network. Next slide, please. Around what you would consider measuring for your CPESN, this is clearly one of the domains of the Quality Assurance and Performance Measures Workgroup. And a couple things to consider here. First of all, you want to think about what is your local CPESN rallying around. I'm going to use prescription drug abuse, opioid overdose, and pain management as kind of an example because I think that's safe to say we have a nationwide epidemic going on with that right now. For instance, in North Carolina this summer, our General Assembly and Governor signed a statewide standing order for pharmacies to dispense naloxone. We were actually, many states had that ahead of us, but once we did have that, we created a special service set for our CPESN pharmacies that allowed them to go above and beyond, not just dispense the naloxone, but do risk assessments with patients and communicate to providers and provide more detailed education to patient about what's creating their risk and how to administer the naloxone. Those types of services, when you establish them within your network, you might want to monitor, has a pharmacy undergone specific training relative to that, or do they, how many of their patients that have high-risk opioids or high-dose opioids that they've dispensed naloxone, for instance. There's also the overall premise of what a community pharmacy enhanced service network is all about, and clearly part of it is overall connectivity to the care team. These aren't just about community pharmacies operating differently in isolation. It's really about changing the practice model a little bit and really facing toward those partnerships that I listed on the previous slides, working closely with providers, hospitals, and others to provide better care for patients. Along those lines, you may have providers who refer patients to you. Well, are they satisfied with the services from your pharmacy? Did they see changes and improvements in the patients they refer to you? The other thing to consider around measurement is clearly one of the things you want to do as an early network and as a mature network is really be able to demonstrate to payers, partners, and others what your unique value is as a network. And so the measures that are chosen should be things that you would expect to be different in these pharmacies compared to the rest of the community pharmacies that don't participate in the network. Next slide, please. Considering potential data sources is a little bit more challenging. We are fortunate in North Carolina that we are operating in a very data-rich environment. My organization, Community Care of North Carolina, we have all of the Medicaid claims data, and we use that regularly to risk stratify our population and to help provide our population health services. But clearly not all emerging CPESNs would be in that environment. And mind you, even we have it only for Medicaid and Medicare as part of the grant, but not for any other payer source or patient population. And so part of what you need to consider as an emerging network is you've identified who your stakeholders are, you've identified what sort of things you might want to measure quality for in your network, but then there's the challenge of the data. Is there data for that particular thing? And so I would recommend you do several things. First of all, you can look internally. What do you have access to either within your network or within an individual pharmacy? It might be something like med adherence data that many pharmacies can pull out of their pharmacy management system these days. It might be something like the percent of patients at each pharmacy that are enrolled in a, we call it clinical MedSync program, and as an indicator of how many of your high-risk patients are really receiving those services. You could also create a scenario where your local kind of administrator or facilitator of the CPESN is collecting information, maybe about quality incidents from the care team, or again surveying those referral sources on their satisfaction with the patient referrals they send to your pharmacy. The other option is you can certainly track clinical measures. If you have diabetes programs or smoking cessation programs, Again, my example earlier about patients on high-dose or high-risk opioid regimens that have access to naloxone, those are data points that you could collect internal to each pharmacy, and yes, we would be relying on self-reporting and that people would accurately report that information, but it would at least provide a data source. To the extent you find yourselves working with either a payer or a specific partner that can get access to claims data, or perhaps you're working with a hospital partner who has information about readmission rates, then you're really able to get into deeper data that get into more global outcomes of patient care. And clearly that's where the meat is, but that data is also harder to come by. So those are important considerations as you're establishing your quality strategy for the network. Next slide, please. There's several different types of measures, quality measures, that you can look at as you're forming your network. Structure measures these are the easiest ones to gather data on. They might be things like, let's say your network says that in order to join the CPESN, pharmacies have to participate in X, Y, and Z training modules. Well, completion of those training modules could be one thing you look at. Or let's say for a specific service set, you like the naloxone dispensing, maybe the pharmacy or a pain management service, maybe you're offering specific training for those pharmacies to make sure they have a certain level of knowledge about pain management or risk for respiratory depression and overdose, and so participation in that training would be a structural measure. You could also look at, if you're a diabetes management service, if that happens to be one of your service sets that your network chooses to offer, then you could look for specific certifications or credentials of staff members, maybe a CDE, for instance, on staff. Process measures are obviously pretty easy to come by as well. Those can be internally monitored and reported if need be. An example might be if you're working with a hospital partner. Clearly, if you do med reconciliation, 30 days after discharge, we've obviously missed the window of opportunity at that point. But maybe you're working with a hospital partner and they say, well, look, we'll send patients, refer patients to you at the point of discharge, but we want to monitor the percent of them that have had their med reconciliation completed at 3 days and 7 days post-discharge. And so maybe you monitor those as processes. Outcomes are obviously, these are the hardest data to get, but again, they really speak to how are patients doing better in the care of your network pharmacies. These could be intermediate outcomes like medication adherence, or they could be global outcomes such as total cost of care or admission or readmission rates to the hospital. Measuring patient or care team satisfaction is also another way to get at outcome measurements. Next slide, please. This gives you an example of what our quality assurance infrastructure looks like for the North Carolina CPESN. And again, recall that right now we have the CMMI funding that's fueling part of this. So we do have a fairly robust set of quality and performance measures that we have in place. They're a mixture of medication adherence measures and those global outcomes, so hospitalization rates, emergency department visit rates, and also total cost of care. And those plus medication adherence measures make up our current measures for the network, but we've also started with the patient experience surveys that you see on the slide. We now have a survey, and we're beginning to administer that to patients statewide who are participating in the network. We also have a process where the care team can report quality concerns. So, we've had things come up where, let's say a care manager tries to refer a patient to a pharmacy for a certain service, but then when they try to make the referral, the pharmacy says, oh, well, yeah, I know we said we provide that service, but we actually can't do it for this patient because they have less than 5 medications. Well, those are the sort of things that would be helpful for the care team members to know in advance. The other example I can give is we had a care manager working with a pharmacy, a patient with diabetes who were having trouble getting access to the insulin prescription, and the pharmacy attempted to contact the doctor, but then kind of let it go at that and didn't ask the patient if they were out of insulin or anything like that. Turned out the patient was out of insulin completely, got very hyperglycemic that night and had to go to the ED and I believe was hospitalized for a short stay. And so that care manager reported something to our network infrastructure here in North Carolina saying, hey, I really feel like a pharmacy that's focused on global patient outcomes, total cost of care, et cetera, really should have gone further to try to get that patient's insulin prescription resolved that day, because look at this outcome that happened, which is obviously not desirable. The other piece we have in place, and this is very specific to our CMMI grant, the other three pieces are not, but this last piece is the care plan quality reviews. For our payment model that the North Carolina pharmacies that are testing, they have to submit a care plan for each patient that gets an intensive intervention, and our partners at the UNC School of Pharmacy have done reviews of those care plans, essentially quality reviews, and given the pharmacies feedback on those over the first 2 years of the grant. And Megan Smith, who's going to be talking with us in a moment, was very integral to that process in her time at UNC. Next slide, please. So I just want to take a moment. There's a lot of information about quality considerations. I just want to take one step back and go back to what John was talking about at the beginning of the presentation, which is as you consider CPESN and what's in it for me in my pharmacy, I would recommend to you that you think about all these work groups and the efforts of CPESN, but ultimately what we're trying to do is express the unique value of community pharmacies, and particularly the community pharmacies that are oriented toward the provision of these enhanced services, and really connecting to the care team. If you think toward value-based care, it doesn't matter what environment you're in. If you're talking about even a hip surgery where there's very little medication involved, even something like that where they're now facing bundled payments where the surgeon, the hospital, the physical therapy team, the outpatient follow-up, where all of that is under one payment. That, even that scenario, obviously those providers are working with each other much more closely than they ever had to in the past because of these new value-based payment strategies. And eventually pharmacy is going to be plugged into those as well. So really what we want to do in this, throughout this CPESN, both your network launch and as we get to mature networks, is to figure out ways to express that value to the care team and make those care team connections. In the short run, it's going to be the referrals from maybe hospitals that are discharging patients and sending them to you for transitional care, or providers who are partnering with you on a smoking cessation or diabetes program or what have you. It's going to be those referrals and potentially the prescription business associated with it that will help sustain your business in the short term. In the longer term, once we start expressing our value, then it's easier to pull in payer partners and be able to say, well, we've demonstrated a difference in quality that's associated with these pharmacies, and because there is value there, it really means better quality and hopefully for a lower cost, then that means that lower cost that the payers really have money to be able to fund these models moving forward. Next slide, please. And I wanted to offer this last slide before handing it over to Megan to just reinforce again what this whole structure looks like. Ashley probably shared this with you last time, but we certainly recognize that it's easy to probably get it all confused in terms of who's participating and what's the role of the work group, and what do our collaborators and partners do versus these folks in North Carolina who are trying to help. And so we put this slide together to try to explain what it looks like. Obviously, you as the participating pharmacy are in the middle of the circle. You're the CPESN work groups we just talked about, service sets, quality assurance and performance measurement, and network operations and communication are right there in the middle with you. So you really make up the core of the local CPESN. Obviously, you're interfacing with all different folks around patient care in the medical neighborhood. So hopefully you're interfacing with certainly primary care and specialists. Hopefully you're connected with hospitals and care managers and maybe even some home health type facilities or rehab. And then on the other side, you have your luminaries and your local CPESN that are really offering you that support and sharing best practices and talking through how to improve different quality measures or how to rearrange your processes in order to be able to handle time-sensitive care transitions, things like that. And then you have your collaborators and partners that are, again, they're helping to facilitate. They might be helping measure performance, things like that. And so hopefully this gives you a picture of where your pharmacy might fit in with all these different terms you hear us talking about, the luminaries, the work groups, what your collaborators and partners that are on the line today would do versus your interface with the care team. So with that, I thank you for your attendance today. I want to hand it over to Megan, and then of course I'll be on at the end to address any questions you have.
Unmuted.
Thank you very much, Trista. This is John Vinson again, and I just have an announcement to make before Megan begins hers. If you want a copy of the slides, there's a PDF copy of the slides under the materials box in your GoToMeeting, what do you call, I don't even know what you call this, your box, your operational box on that you control your audio. There's a section called materials, and there's a PDF file if you'd like to use it. All right, with that, we will introduce Dr. Megan Smith. Thank you for being here today.
Thank you so much, John, and thank you, Trista, so much for joining us and giving that great background as well this morning. Yeah, okay, sorry, John is giving me things to say. So it's a pleasure to be here on the webinar today and to get to meet with you all, at least virtually, and hopefully one day I can meet with everyone personally as well. I'm going to take probably about 10 or 15 at the most minutes to tell you a little bit about myself and my background, and then how that relates to the work that we have going set before us in Arkansas. And so that should leave us with about a good at least 15 minutes for questions. So go ahead and be thinking about those. Type them into the chat box, or when we get to that, when I'm finished and we're able to take questions, we'll have further instructions where you could probably raise your hand and we could even unmute you and you could ask verbally as well. So go ahead and be thinking about those. So today I'm actually sitting in Little Rock. I'm here at the Arkansas Pharmacists Association, sitting next to John Vinson, as you probably have guessed. I am a new faculty at UAMS, but I am a transplant to Arkansas. So I'm going to start with my North Carolina background, and then we'll connect it to what we have for the work ahead. And just as a level setting a little bit, that I am a UNC grad, so I am a pharmacist. I graduated from UNC Eshelman School of Pharmacy, and I did do a community pharmacy residency with one of our regional chains in the state of North Carolina. And then after that residency, I began a 2-year academic and research fellowship at the University of North Carolina, and that is how I got to be a part of this wonderful CPESN experience, and got to meet Trista and Ashley Branham, who's also on the line today, and was able to be a part of the foundational work. So that was really exciting for me. And as I was part of that 2-year fellowship, I basically spent most of my time on the quality assurance and performance measurement work group. Here are the work groups again. I know you've seen them quite a few times. Maybe by the end of this you'll have them memorized. But this work group, I did several different activities. Some were related to my research experience and trying to gain skills in that area, and others were to the CPESN network development, and really those early phases of what does this look like, and a lot of the things that Trista has already has described today. So today, one of those with when Trista mentioned about the care plan quality reviews, that was kind of wearing my research hat, but today we're going to focus on more things that you might be seeing in your future, and I'm going to focus on the early stage with some of the early phase with my examples, just because I think it might best relate to where we are in Arkansas. So first, on this slide, this is the same work group. There's a slight name change here, and I probably should have updated that just to reduce confusion, but the field site assessment and QA work group is the same and synonymous with the quality assurance and performance measurement one, and with the definition that you saw on the previous slide. And I really like timelines. I think it puts things into perspective. So there's a timeline on the bottom, and in the green box labeled launch is when our community pharmacy enhanced services network actually launched. We had participation agreements in hand, and everybody was marked go. So step one with our group was for a timeline before the launch happened was, I'm doing the wrong computer. to create a working definition for comprehensive medication reviews. Now, what I'm talking about here is one enhanced service, a part of the multitude of service sets. So this was one, and I'm focusing on this one because at the time it was something we had access to, and it was something tangible that we could work with from the get-go. So first of all was just defining what that is, that it was a high intensity and longitudinal service, and we even defined it to the granular level of what specifically this means and which is each step to perform a comprehensive medication review. In other words, how did this look for for our CPESN pharmacies? The next step was kind of in tandem with that, which is to define for our participating pharmacies what the service definition was. Example such as documentation requirements and who should be receiving CMRs, how to perform the CMRs, or how often should these be done, and kind of those requirements of the pharmacies and the pharmacists themselves. Then next we developed and conducted a baseline survey just to collect information about all of the pharmacists and the pharmacies that were participating in the network at launch. Things like just the types of pharmacies they were and their staffing structures, so that we could know really just who was a part of the network and if there were any ways that we might be able to use that data later on. Then our fourth step was to evaluate the initial CMRs for engagement. So I have this described in the next slide, but just so you can see, this fourth step took about the first 3 months. After the launch, we wanted to see how pharmacists were doing regarding implementing this new service and the new ways that we had defined it, and ultimately we wanted to know how to help them. And so this slide shows you what our initial discussions were, and it was kind of our first quality measure per se. We noticed in the first couple of months that there were some pharmacies who hadn't started providing the service at all, or at least had not documented it as far as we could see on our end. So we labeled those non-engaged pharmacies. And then there were some that had inconsistent engagement, meaning that they did some CMR some months but not in others. And then there were those who hit the ground running and were able to implement this into their workflow from the beginning and provide the service consistently over time. And so the goal for the quality side was to move pharmacies from the left to the right. How do we get everybody to at least be consistently providing the service? So not focus so much on benchmarking of high volume or anything like that, but just get them doing it consistently. As you can see here, it was just the threshold was very low of just doing something, do one CMR. So this was how our conversation started. But of course we did a lot more than that, and I'm just summing that up here for you on this slide. With the engagement piece, we defined what you saw on the slide before, but we also devise strategies of how to move people from, or pharmacists from the left to the right, how to become and provide this service consistently. Then we next moved to drug therapy problems. How did we define those? How did we identify them and monitor them? And there were issues surrounding that, both from a clinical standpoint, but also from how do we track this, and what's the best way to track it, and things of that nature. And the last one there is kind of another quality measure that we were discussing, which is service completion rate for high-risk patients. So as part of the definition for the CMR, we had we were encouraging that these be completed on high-risk patients, and we had a way for pharmacists to know who those patients were. So this was just a measure to see were the right patients being targeted for the intense service. And then lastly, throughout all of this, we were developing guides and templates to use that pharmacists could use either to help them with documentation or how to keep track of their activities, or helping them just become more familiar with all of the materials we were providing, the training documents, but then also, like I mentioned, we provided them with high-risk patients and helping them to know how to even I just lost my train of thought, but how to work with the spreadsheets that we were giving and the data that we were giving them, and making sure that kind of retraining on some of those initial documents. So that's sort of some of the things that we did in North Carolina and our initial steps. Now to transition to Arkansas, and what brought me to Arkansas is on the right here we have a lovely map with all of our community pharmacies on there. And so community pharmacy was very strong in this state as I started to do my research on the state. And so I am so thrilled to be able to start traveling out of Little Rock and meeting some of you all personally. I've heard so many good things, both from people within the state, but then those outside of the state about your community pharmacists. The University of Arkansas for Medical Sciences had a strong focus on community pharmacy and was wanting to see innovation and wanting to see support in this area, as well as from the Arkansas Pharmacists Association and the State Board of Pharmacy. So when I was receiving all this information and doing my research, I thought this is the place I have to be. So I'm excited to be here with you all. So what does that mean for us? I keep doing the wrong computer. What does that mean for us here now in Arkansas? Kind of taking some cues from what Trista presented earlier, we're going to start in some of those same initial steps, establishing our organizational foundation for QI and QA. So what is that work group, who's on that work group, and what are all the, what's the infrastructure of the work group? We are going to determine our stakeholders and see what is valuable to them, and see how thank you. Determine our stakeholders and see what is valuable to them, and have that as part of our conversation, and inviting them in as well. Selecting our quality goals, structure, process, and outcomes, as we had some good examples from earlier. So we will discuss those and see what do we want to start with, and what do we want to be a part of our network. Again, we'll align that and work with our other work groups for service sets work groups, so it should be aligned. Your quality measure should be aligned with what the pharmacy is actually performing. So we'll go through those exercises as well, and therefore then identifying and evaluating our quality data lastly. Now that sounds like a lot to do. Does it not seem like that, John? That's a lot to do, and that's a lot to ask of our community pharmacists who are busy taking care of our patients. So I am excited to say that we have some great organizational support to help you all. At the end of the day, we understand that you are the ones that are providing this service and are helping taking care of our patients in Arkansas. And you are going to be helping to drive some of these major decisions of what the network looks like, how do you want to band together, what's important to you. But we also can realize, like, all this work, you might be very difficult to do that on top of running your business and taking care of your patients. So we have a great partnership set up for you between the Arkansas Pharmacists Association, the UAMS College of Pharmacy, and Harding College of Pharmacy. All three of us are banding together and are wanting to support you. We have already identified a few ways that, for example, Arkansas Pharmacists Association, you will notice them hosting these webinars. Thank you so much, John. They are really great at communicating and advocating for you and taking the issues that you're seeing and translating it to our legislative issues. And they're also great for consulting, and they'll be still a part of your, if you are a member of APA and call them regularly, they'll still be there to answer your call and will field your questions about CPESN as well. From UAMS College of Pharmacy standpoint, we were brainstorming and thinking if you would like some additional educational opportunities. Is there something that you need to help your professional development to engage within this network, then we're going to provide those. We're going to help you evaluate. So on the last slide, when I mentioned there's a lot of work there, again, you can help drive those discussions and drive the decisions, but then pass it off to us to help you do the evaluation, and we can bring the data back to you so you can further and make your next steps and your next decisions as we move forward. And we can also help disseminate all of that information as well. So disseminating through press and through publications and through a variety of means. But the bottom line is all of us here are have set aside resources to help make this successful if this is something you would like to be a part of and like to see happen in Arkansas. And for a lot of the reasons that John mentioned earlier, there's some great practice innovation, but also some personal financial benefits to being a part of this. But we do need to hear where you are at and what you would like to see in Arkansas. Yes.
I just want to make a quick comment too that that list is going to grow. You know, partners, including, you know, we have a great relationship with the State Board of Pharmacy. Megan and I and Scott Pace met with Brandon Griffith and Wendy C. from Blue Cross Blue Shield this week, you know, and talked about this network and what ways they may could advise us or help us, you know, develop this out or really help with maybe the data side through the Arkansas all-payer database. You know, ACI might be a potential source of help as a resource. The Arkansas Center for Healthcare Improvement. That list is going to grow, but those three organizations are absolutely, you know, rock solid, going to support in any way we can.
Absolutely. Thank you so much, John. And just to wrap back up with this timeline that John shared with you at the beginning of the webinar today, today at this point we are actively recruiting and trying to see and field out who all is interested in this network and who would like to be a part of these work groups to help determine and define what this network looks like for Arkansas. We're planning these things coming up for the work group meetings and establishing the framework to get started, but right now we are wanting to hear from you. We want to know if you're interested in being a part of this, whether as a participating pharmacy or if you have the resources and time that you could serve on one of these work groups to help us define this going forward. So how do you do that? We really want well, I've already mentioned this, but here it is again for the third time today is all of our work groups and the definitions of each of those. The live work group meeting, I will get to that in a second, but we are looking for volunteers for these work groups because this is something that you guys are going to drive and lead. It is not something that John or at APA or I at UAMS is going to define and tell you what to do. You're going to be the ones making those decisions. So how do you do that? We really want to stay connected to you, and we want to know who is interested in beginning this for Arkansas. This is the Arkansas Pharmacists Association's website. It's arrx.org/CPESN. And when you go to this website, there's two ways to get there. This /CPESN is directly to the page that you see here. This I took a screenshot of. And where there is a big red arrow, it says stay connected, complete this form. And so if you click that, you'll be taken to this screen, and it's a very basic form of just basically your contact information so that we know you are interested in wanting to stay updated on all of how this may progress and any new updates that we may have or updates on trying to get work groups together. Where this arrow is on this slide, it says, would you like to be involved as a CPESN leader or a member of a work group? And then once we receive all of those who may be interested in a work group, we'll definitely keep you in the loop as well about the scheduling of this live meeting where everyone can get together, and we can really start to at the meeting we'll have some guest speakers like Ashley Brandon from North Carolina and maybe some others, and will help walk us through the formation of those work groups and begin that work. So we really encourage you to fill out the form to let us give us your contact information so that we can keep you abreast of all new information. But then also, please don't ignore that question. We want to know if this piques your interest at all. And even if this is not a commitment signed in blood, you can definitely change your mind later if you're not sure if the commitment or the time you have the time to be able to do it. We can definitely be flexible with you. This is really just an initial trying to get everyone together. So please go to this form and indicate if you could serve on a work group, or even if not, you're just interested in staying up to date or perhaps participating in the future. We will definitely keep you in the loop. So just to wrap up, these are your points of contact. John Vinson there on the left, and I'm in the middle, and Ashley Branham there, who we haven't heard from her this webinar, but she was the one who led the first webinar, which is available on the Arkansas Pharmacists Association's website. You could listen to that webinar on the website and hear her beautiful voice there. She is our contact in North Carolina, and she's going to be part of the team that helps us as we continue to develop and grow this in Arkansas. So thank you so much for that. I think we have about 10 more minutes for any questions.
Yeah, I have a couple of questions that have been sent to me, and we may have some on the chat too, but I just wanted to kind of touch on the concept of a CMR, in quality, a comprehensive medication review. And let me see if I can get Trista as well, make sure she's available to make any comments that she may have. But so the question is, I've heard a lot about quality and about CMRs and medication reconciliation and transitions of care and decreasing waste. Why haven't, in the webinar series and the information I've heard, why hasn't the term MTM really been used that much? Or is MTM completion a part of the Enhanced Services Network, and kind of what's the difference? That's a hard question, but that's one of the questions I've gotten.
Well, John, I can take that one if you like. This was a question we got really common,
Muted.
as you might imagine, when we first launched the North Carolina network, in particular because with our grant, some of our participants are taking care of Medicare patients who are eligible for MTM through Outcomes or Marixa, and then through our grant they're able to provide different services which are kind of an enhanced CMR. We're not even calling it a CMR anymore because it's a very in-depth intervention, and a CMR doesn't quite fully describe the depth and breadth of it. But essentially why we're not really talking about MTM is because in the realm of enhanced services, there's well, first of all, there's a lot to focus on. We're talking about everything from, again, being willing to dispense naloxone on a standing order, to doing MedSync, to having translator services available for patients that don't speak English, to you name it, right? Adherence packaging, home delivery, all these types of things. And then we're looking at, so those are kind of related to dispensing, let's say, but they're kind of like enhanced dispensing services. Then you have some of the clinical type stuff, smoking cessation, diabetes management. Then there's sort of comprehensive med review, which is obviously taking a very complete look at all of the patient's medications and disease states and evaluating what could be optimized that's not currently optimized. And so a couple of things why you don't hear us talking about MTM. First of all, our focus is more on enhanced services and the entire breadth of what I just listed, knowing that, for instance, in North Carolina, we have north of 250 pharmacies in our network now, but only about, I'll say 150 to 175 of them are participating in the CMR type enhanced services, but many others are doing MedSync with packaging and home delivery and working closely with care managers, potentially even going out doing a joint home visit with care managers, things like that. So not every pharmacy can engage in the same type of services. So that's why we're focused on enhanced services and those that we think bring some kind of improvement in overall patient outcomes related to med use specifically. And around the MTM term, I think really what we have found, at least with our project in North Carolina, now keep in mind, as John said at the beginning, CCNC has been working with Medicaid patients, and the pharmacy program's been working with Medicaid patients for 10 years. CCNC has been working with the Medicaid population here with pretty good success and outcomes for much longer than that, more like in the 15 to 20-year range. And what we have found over time is that especially for really high-risk complex patients, for most payers, it's that high-risk complex patient group where you can really make a difference in overall outcomes and utilization. It's kind of the old Pareto rule kind of thing. The top 20% is probably utilizing 80% of a particular payer's resources. And so really focusing on that, whatever it is, 5, 10, 20% of the sickest patients, highest risk patients, That's where the benefit is. What we've known through CCNC, working with those patients, they are very complex. They have multiple chronic illnesses, very complex medication regimens, and MTM is a little bit too much of a light touch intervention to really dig in and be able to get it to outcomes with those folks. The other thing is our North Carolina pharmacies have told us these patients require follow-up over time and coordination with the care team. And MTM doesn't really include those pieces, and yet we have found that the follow-up, not so much the initial intervention is important too, but then the follow-up with that patient and the care team over time is so critical, and those parts just aren't traditionally considered a component of MTM. So hopefully that goes a little bit of the way to addressing that question, John.
When is the yeah, here we go. Another question that I see on the chat is, when is the presentation from Troy Trigsted? And Trista, can you remind me what Troy's official title is? Or what his...
Sure.
Yeah.
Yeah, he's Vice President of Pharmacy Programs here at CCNC, so he was the initial, essentially, creator of the pharmacy programs here, and he is our director of our CMMI award, which is the grant project that's currently funding the Community Pharmacy Enhanced Services Network dissemination efforts.
In other words, he knows what he's talking about.
He sure does.
He's a nationally renowned, recognized speaker, and he's coming to UAMS on Friday, October 7th from 12 to 1, and anybody who's interested would certainly be welcome to attend that. To repeat the date, here in Little Rock. And of course, we can get more information about room location and that kind of stuff as it gets early next week to folks. Another question that I've gotten is, on both presentations, I've heard about risk stratification, and I've had some pharmacists in Arkansas say, hey, I've got Pioneer software, and I've noticed that they've started adding a risk stratification section, and I wondered if Megan or Trista, either one, knows much about that Pioneer integration, if that's anywhere close to what you're using in your quality realm of trying to determine who those high-risk patients are.
Absolutely. Those Pioneer pharmacies in North Carolina see the same risk score, actually. We're able to empower their scores here with a little bit more data. So Pioneer pharmacies outside of North Carolina are getting risk scores based on the data in the pharmacy system alone. The ones that are working with us in North Carolina, we have access to the entire patient claim, so those are a little more maybe high-powered risk scores, if you will, a little bit more informed because there's a richer data set available. But yes, those are the exact type of risk scores that we're talking about, and they really allow a pharmacy to start understanding who within the population that they serve, who are the highest risk patients. So for any of them that receive the scores currently, obviously someone that asked this question probably does. In North Carolina, our efforts have primarily been focused on those patients with scores greater than 75. And our pharmacies in North Carolina who have now delivered services to, it's definitely over, 10, probably 15,000 folks at this point in the grant, at least as we enter year 3. They have absolutely said that those risk scores tend to correlate very closely with, who they know to be their high-risk patients in the pharmacies, and that these folks, once they start working with them, even if they didn't realize the nature of their risk or the complexity of all their illnesses before sitting down with them, that certainly after sitting down with them, they recognize the medical and the medication use needs that they have, and potentially some of the enhanced services needs that they really need to support their overall med use.
Awesome. So that's a perfect example of where we may have at least a rudimentary ability to do something similar to North Carolina could do, and that work group, whoever serves and is interested and helps with the quality improvement performance work group, probably can start talking to folks at the payers, the all claims database in Arkansas, and see if that could be replicated here or something similar.
Yep, absolutely. Any place that has those types of data sets. And we're also working with some of the other pharmacy vendors here in North Carolina, so at least for our North Carolina stores in the coming couple of months, there will be several other vendors who are likely also displaying risk scores for the pharmacies. So that's, in a lot of ways, that's kind of the first step to really understanding all the patients in your care and who might need the most intensive services that you offer. Great question.
All right. Any other questions? Any other comments? Anything you want to add, Megan? Okay, once again, I appreciate everybody's time today. This webinar will be or has been recorded, and next week it should be on the website after we are able to load it up on the APA website at the www.arrx.org/CPESN. And I appreciate Dr. Pfieffenberger, Dr. Smith, Dr. Branham, and everybody have a great weekend, and we'll see you soon.